Okay, I guess we can start. So welcome everyone for another Monty Har. Today is a great pleasure and honor to have with us Dr. Alexios Antonopoulos. Dr. Antonopoulos is gonna talk about a topic that is of my interest, and it's kind of very exciting and very contemporary in a way. He's gonna lecture us about the use of cardiac imaging in pericardial diseases. Dr. Antonopoulos is an imaging cardiologist and a clinical scientist at the Hippocratean Hospital, the University of Athens. He completed early training in medicine and cardiology at the University of Athens, and then he went to complete postdoctoral fellow, the Marie Curie postdoctoral fellow at the University of Oxford. He then did different trainings, including advanced training in CT and MR, advanced CT and MR in the UK. He has been, part of numerous numbers of papers, particularly looking into risk markers for disease using imaging, sort of like an imaging biomarkers. One of them, or few of them, of great interest in the realm of coronary artery disease and pericardial diseases with association with pericardial fat. He has been supported for some of these kind of research endeavors by the European Society of Cardiology and the CMR unit, Royal and Brompton Hospital. He currently serves as the executive director for the Hellenic Journal of Cardiology. Again, Dr. Antonopoulos, it's a great pleasure to have you here. We're so eager to learn and to see what you have to say to us about the use of imaging in pericardial diseases.
Thank you for your kind comments, and it's a pleasure for me to be here with you. So I'm mainly practicing CMR nowadays, but I promised to you that this lecture won't be only about CMR. So I have put a bit of multimodality imaging too in my slides. So this is my disclosure slides. I have no conflicts relevant to this presentation, but I should state that I'm a CMR fan in pericardial syndromes. And this is what I will try to talk to you about in the next few minutes. So we know that this is how the normal pericardium looks like. So it's essentially a sac that contains the heart. It's the fibrous pericardium and the visceral layer. And in between, there is the pericardial cavity that is filled with some fluid. We should be aware that the normal pericardium extends superiorly up to the level of great vessels and surrounds the superior vena cava and the pulmonary tract and the aorta. And this is where the pericardial recesses are formed, something that may be of clinical significance in occasions of pericarditis and pericardial effusion collection. So we can use almost any modality, any imaging modality to look into pericardial syndromes. Echo is, of course, the first-line modality that we use. It cannot really visualize the normal pericardium. This is how it typically looks like in the parasternal long axis, but we cannot really assess either its thickness or collect information about underlying pericardial inflammation. However, echo helps us to visualize any pericardial effusion in cases of suspected pericarditis. And we also, of course, get information about the function of the left ventricle and any constrictive physiology present. While here, you can, on the right side of the slide, you can see how CT is it okay? Did the presentation stop or?
Yeah, I think it just kind of went off. We're connected. maybe you can, I don't know if on your end it stopped. Yeah, that we have it. Good.
Okay, so I was saying that this is how pericardium CT looks like. This is a case of heavily calcified pericardium, and this is how a 3D reconstruction of a heavily calcified pericardium looks like. However, CMR has a special role in imaging of pericardium, as we can typically have many different information about pericardial physiology, anatomy, and presence of inflammation. So this is a typical cine image. We should be aware that this is how the typical pericardium looks like on cine images on CMR. This is the black line separating epicardial fat from the Sorry about that. I'm not sure what's going on. Did you still see the slide?
I think not yet, but is closing on your end or just make sure that it's nothing from our end. Is the presentation closing?
Definitely nothing. No, it's definitely nothing from our end. Doctor, okay. If you can maybe turn off your screen, your video.
I could, but I don't think it's a bandwidth issue. But in any case, I can turn off my camera.
Yeah, let's let me know.
Okay, so if we want to visualize pericardial thickness, then we have to switch to. We have to switch to turbospin echo images, T1 weighted images, to get rid of the chemical shift artifact between epicardial fat and the myocardium, and we are typically assessed pericardial thickness on these images, while T2-stir images can be used to get information about pericardial edema, pericardial inflammation, and the same applies also for late gut imaging of the pericardium, where we should be able to see any signal, high signal intensity in cases of inflamed pericardium. Typically, a normal subject, a normal without any pericardial inflammation, shouldn't have any high signal intensity on either T2-stir or late gut images. While even PET can give some information about pericardial inflammation, you can see here a case of pericardial tuberculosis, where you get all this high signal intensity, the high SUV of the pericardium, suggesting active ongoing inflammation. And PET may be of potential clinical use in cases of, as I said, tuberculosis or solid cancers and lymphomas. So multimodality imaging in pericardial syndromes, I have separated my lecture in these sections: acute and recurrent pericarditis, pericardial effusion, the use of imaging cardiac tamponade, and constrictive pericarditis. And I will talk also at the end about pericardial masses and cysts, as well as for congenital abnormalities of the pericardium, which are rare, but one may encounter in clinical practice. So for acute and recurrent pericarditis, on this side of the Atlantic, we typically use these criteria as set by the European Society of Cardiology. We need to have at least 2 of these 4 criteria to diagnose acute pericarditis. And you may note that these are the guideline recommendations published back in 2015. We wait new guidelines, clinical guidelines, to be published soon, this or the next year. And you may see that back then, in those clinical recommendations published in 2015, CMR is not included in the major diagnostic criteria. We have pericardic chest pain, pericardial rubs, ECG changes as widespread ST elevation or PR depression on ECG, and pericardial effusion in a relevant clinical context. And on top of that, supportive findings such as elevated C-reactive protein levels or imaging evidence of pericardial inflammation may be used to diagnose pericarditis. Of course, all this has changed in the recent years with the increasing use of CMR in everyday clinical practice. Would it be possible to turn off your microphones because I can hear some noises in the background? Thank you. And on echo, as I mentioned earlier, we typically don't see much apart from some pericardial effusion in a patient with acute pericarditis, and we may also observe this diastolic and diastolic collapse of the right atrium in cases of pericardial fluid accumulation around the right chambers of the heart. However, by using CMR, we can get much more meaningful information, not only about pericardial anatomy, but most importantly, about the presence of inflammation. Therefore, high signal intensity on T2-stir images and on late gut images is equivalent to active ongoing pericardial inflammation, and this is the hallmark sign of acute pericarditis. In this case, you can see an acute pericarditis without any effusion, but of course, we can typically see also acute effusive pericarditis cases like this one, where you can see all this pericardial effusion around the left ventricle in the lateral wall, high signal intensity effusion on T1 mapping suggesting of pericardial transudate, and increased signal intensity of the pericardium on the late gut images, again, characteristic feature of acute pericarditis. Other types of acute pericarditis may be observed, such as acute myopercarditis, when we have myocardial involvement with elevations in cardiac troponin and late gut in the myocardium, or pericarditis post-myocardial infarction. You can see here a case of anterior MI associated with effusive pericarditis post-MI. While on the later stages, there is a resolve of pericardial inflammation, and typically subacute pericarditis do not have any striking findings on T2-stir imaging, but we can observe some signal intensity on the late gut images only. In this scenario, we are not entirely sure whether this late gut may signify ongoing inflammation of the pericardium in the absence of any clinical symptoms or not. So some LG may be observed after a pericarditis event, an index pericarditis event, and could be seen on follow-up CMR images without signifying active pericardial inflammation in the absence of any supporting symptoms. While chronic pericarditis, we may have increased pericardial thickness and no LG because of no active inflammation in the pericardium. So there is acute pericarditis is a multifaceted disease. We can observe in everyday clinical cases all these types of pericarditis, and CMR is useful in diagnosing each one of them. And after an index case of pericarditis, this is how the imaging appearances of pericardium typically look like. So after an index case with high signal intensity and T2-stir images and late gut, there is the resolution of pericardial inflammation and the signal intensity drops over time, while ongoing symptoms and active findings on CMR may signify recurrent pericarditis. After multiple pericarditis events, then we may not see any inflammation at all, but the patient may develop a thickened pericardium that may lead to constriction. And this is something that we will discuss a bit later on. So the use of CMR has indeed been a paradigm shift in the management of recurrent pericarditis, while typically over the last few years, we base our treatment decisions on clinical symptoms and C-reactive protein levels, for example, for up titration of treatment or the tapering of corticosteroid treatment. There is a problematic in this strategy because symptoms are often atypical in patients with acute pericarditis, and inflammatory markers such as CRP are not specific, neither sensitive for pericardial inflammation. And therefore, imaging, especially with cardiac magnetic resonance, helps us a lot in everyday clinical practice, both to diagnose atypical cases of pericarditis and even to guide our treatment decisions when to up-titrate treatment or even tapering the dose of corticosteroids. So even though in the European guidelines, pericardial LG is not included yet in the main diagnostic criteria for acute pericarditis, in everyday clinical practice in centers of excellence with availability of CMR, we typically base our everyday clinical decisions on pericardial LG to treat our patients, and especially patients in cases with recurrent pericarditis. So as I said earlier, pericardial LG may be detected after an episode of acute pericarditis, and this does not always mean active pericardial inflammation. Typically, we should see pericardial LG to be resolving over time after an index case of pericarditis. And during the acute phase, we typically see high intense LG, which is equal to pericardial inflammation, while during the chronic phase, high intensity LG of the pericardium may signify pericardial inflammation or recurrent pericarditis. However, some mild LG appearances of the pericardium may simply signify some permanent fibrotic changes of the pericardium and not necessarily active pericardial inflammation. What remains uncertain is how to quantify pericardial LG. There are some algorithms for quantification of pericardial LG, and some clinical studies have shown that pericardial LG is predictive of pericarditis recurrence. However, in everyday clinical practice, we do not have any established methods for quantification of pericardial LG, which may be technically challenging. And therefore, this is what I prefer to do, at least in my clinical routine, is to provide a visual assessment of the pericardium and grade the presence or absence of pericardial LG by a semi-quantitative score like none, mild LG, or high-intensity LG, and this may be enough to guide treatment decisions. T1 and T2 mapping in the case of pericardial disease is not particularly useful. In this case, you see an active pericarditis, acute pericarditis after blunt chest trauma. You can see high-intensity T2 stir images, high-intensity late gut images, and high-intensity T2 mapping of the pericardium, which I should say that is not, the most sensitive modality, T2 mapping, to diagnose active pericardial inflammation, given the low resolution of T2 mapping images. So I find more helpful to use T2 stir in my everyday clinical routine and clinical protocols rather than T2 mapping for acute pericarditis cases. T1 mapping may be useful in the characterization of pericardial effusions. You can see here this paper by Rosmini and colleagues. Transsudates, pericardial transsudates have a high T1 mapping, higher than the exudates, and a cutoff value has been proposed to characterize pericardial exudates versus transudates, which seems to have excellent accuracy for pericardial fluid characterization. And if we move on to constrictive pericarditis, in the old days, this is how a constrictive pericarditis could look like. This, you can see on this chest X-ray, the eggshell-like appearances of the pericardium. And if we referred this patient for a cardiac cath, you can see some very rare images of the pericardium, of a heavily calcified pericardium, showing here on the fluoroscopy images. We were dependent on cardiac catheterization to diagnose pericarditis, constrictive pericarditis, by this square root sign, the equation of LV and RV pressures. Currently, of course, we have multimodality imaging that is very helpful in everyday clinical practice to diagnose constrictive pericarditis. Pericardial constriction can be, on most occasions, diagnosed by echo. We can observe characteristic features of constriction, such as the septal flush and the annulus reversus, and the mitral inflow respirophasic variation. And if echo is not enough and does not put the diagnosis of pericardial constriction, then we have more advanced imaging, such as chest CT, where a heavily calcified pericardium can be easily detected. And next to CT, CMR can be also used to assess pericardial thickening and constriction. You can see here the correlation between the pericardial calcifications on CT and the thickened, this all hypointense area is the thickened pericardium as it appears on the turbospin echo T1 weighted images on CMR. But most importantly, CMR can offer also information about ongoing pericardial inflammation. On cases of constrictive pericarditis, we may or may not see active pericardial inflammation, and this may have implications about the treatment decisions we take about these patients. But most importantly, CMR has excellent diagnostic accuracy for diagnosing constrictive physiology. You can see here the ventricular interdependence and the septal flattening during deep inspiration, which is a feature of the ventricular interdependence and constrictive physiology. And of course, T2-STIR images and late gut can assess presence of pericardial inflammation. So nowadays, CMR is invariably, at least in our center, used to take decisions for constrictive pericarditis. You can see here a case of a 74 male with recurrent pericarditis, shortness of breath. Echo shows regional wall motion abnormalities and a mildly impaired LVF, and some pericardial effusion. There are some signs of constriction on echo. C-reactive protein was negative, and there was this question of whether to treat the patient with NSAIDs and corticosteroids plus colchicine. The CMR puts the diagnosis of pericardial constriction. You can see here again the septal flattening during deep inspiration of the patient, as well as the septal bounce, suggestive of pericardial constriction. In this case, CMR showed active pericardial inflammation. You can see here high-intensity T2-STIR signal on the pericardium, as well as high-intensity late gut of the pericardium. By the way, this is a patient with a history of myocardial infarction in the LAD territory. That's why you can see here also this late gut scar at the LAD territory. However, the main pathology, the main abnormality here is the ongoing pericardial inflammation, and therefore this patient can be treated with anti-inflammatory treatment instead of referring the patient for a pericardiectomy, a bout of NSAIDs and corticosteroids plus colchicine can be attempted to guide treatment despite the negative CRP values. While in another case of constrictive pericarditis, again, a male with 68 years old with shortness of breath, bilateral pleural effusions, and heart failure symptoms without any C-reactive protein increased. You can see here again late gut and constrictive physiology, the septal flattening with inspiration, and this patient can be again treated with anti-inflammatory treatment. While in cases where constriction is shown on echo, but CMR does not show any evidence of pericardial inflammation despite constriction, then these patients are not suitable, eligible for anti-inflammatory treatment. These are the typical cases where pericardiectomy needs to follow to relieve pericardial constriction. And you may observe also the discordance between serum CRP levels and the findings by imaging. We know that these two, imaging and circulating CRP levels, may correlate, but this is not always the case, as CRP is not either specific nor sensitive to local processes happening in the pericardium. And therefore, maybe imaging is a better and more suitable marker to guide treatment decisions rather than serum CRP levels. Therefore, in constrictive pericarditis, whether there is suspicion of constriction on echo, the next immediate step is to perform a CMR. At least this is what we do in our everyday clinical routine. If there is CMR availability, then we refer the patient for a CMR scan. If there is evidence of pericardial inflammation, we can commence or titrate anti-inflammatory treatment. If there is no evidence of inflammation, then the patient needs to be referred for pericardiectomy to relieve pericardial constriction. And this is a clinical study that we published a few years ago on what is happening at the RV side of the heart after cardiac decompression by pericardiectomy for constrictive pericarditis. You can see here that there is a significant increase in the size and dimensions of the RV after pericardiectomy, and patients, this huge increase in RV volumes means that there is also some degree of right ventricle dysfunction, systolic dysfunction immediately after the pericardiectomy, and typically these patients may need to stay on inotropic support for prolonged inotropic support after the surgery of pericardiectomy. When we looked into the findings of histology, you can see here that at least in this cohort of patients, you can see that there was always invariably evidence of inflammation and fibrosis of pericardium. Less frequently, there was calcification present, while LG was positive in these cases, or at least mildly present in about 40% of this cohort of patients with constrictive pericarditis. Another interesting finding was that patients that had more thickened pericardium, more heavily calcified pericardium, and less epicardial fat thickness were more likely to need prolonged inotropic support postoperatively. And an explanation for this finding was that it may be easier to peel off the pericardium. The surgeon may be more easily peel off the pericardium if it is not thickened, if it is not calcified, and if there is a thick epicardial fat pad beneath the pericardium, and then it can peel it off, more easily. So in constrictive pericarditis, I think multimodality imaging is valuable. Cardiac CT can assess accurately pericardial calcification and thickness, while CMR allows the measurement of pericardial thickness and the differentiation of pericardial effusions from pericardial thickening. And of course, it has excellent diagnostic accuracy for constrictive physiology, while pericardial late GAD may predict the reversibility of constriction after anti-inflammatory treatment. So cardiac catheterization these days is used only in the case of inconclusive clinical and imaging findings, which I must say does not happen, very often these days. With if we employ all available imaging modalities in the workup of these patients. Some common pitfalls that we should be aware when we assess pericardial anatomy by CMR is that pericardial thickness may be overestimated on cine images because of the chemical shift artifact between fat and fluid, and therefore we should always use T1 weighted anatomical images to assess pericardial thickness. You can see here pericardial thickness looks more on cine images, while on T1 weighted images, this is how the actual pericardial thickness looks like. This is not a thickened pericardium. While pericardial inflammation on T2 stir images may be particularly challenging if there is also pericardial effusion, and we get this appearance of the pericardium, and it's not always easy to say whether there is high intense T2 stir signal on this pericardium or not. Other artifacts is that or pitfalls that we should be aware of is how to differentiate fluid from fat. Typically, fluid pericardial effusion has more signal intensity on cine images, and T1 mapping can help differentiate fat because it gives this characteristic black hypointense signal on T1 mapping. On late GAD images, PSIR, phase sensitive inversion recovery images, typically pericardial effusion fluid appears as a hypointense area, and therefore this can be used to accurately diagnose pericardial effusions at the presence of fluid instead of fat. And if we cannot really understand whether we are seeing fluid or fat on our CMR images, then the fat water separation can definitely give a definite answer to this question. We published previously this algorithm on the multimodality imaging pericardial diseases in case of suspicion of a pericardial inflammatory syndrome based on the typical diagnostic criteria that we use, and an echo of the heart and transthoracic echo is the first step approach. If the image quality is poor or the echo findings are ambiguous, then the patient can go on to perform CMR in case of CMR availability, and depending on the findings of this CMR, whether it has T2 stir signal and late GAD, then this patient may be treated as acute pericarditis. If stir images and LGAD images are negative, then this patient should be treated as a pericardial syndrome only if the inflammatory criteria are met. And in case of constriction, as we discussed earlier, pericardial T2 stir images and late GAD can help decide on what to do with the case of constriction. If there is evidence of inflammation, then a bout of anti-inflammatory drugs can be used, and the patient can be reassessed after 3 to 4 months after resolution of symptoms and normalization of C-reactive protein. If there is no evidence of pericardial inflammation on CMR images, then this patient should be referred for pericardiectomy. And I will go on with this last section, congenital abnormalities of the pericardium and pericardial masses. the congenital absence of pericardium is a very rare condition, but if you do a lot of CMR, you can encounter these cases. The presence of lung tissue between the great vessels is a very characteristic sign that can be present in congenitally absent pericardium, but typically we suspect the absence of pericardium by seeing a heart that is that has changed position. It is located laterally and posteriorly in the chest. And typically, these patients are very hard to image by transthoracic echo. And since pericardium is a very thin structure that may not be always easy to visualize on CMR, what we typically do is scan the patient both at the supine and the prone position. This is the supine position. You can see where the heart lies. It is located laterally and posteriorly, while if the patient is scanned in the prone position, then the heart moves anteriorly closer to the chest. It is the so-called ventral flop of the heart. If the position of the heart then changes during these scan positions, then we can confirm the absence of pericardium. And this is another case. You can see how posteriorly the heart is in this supine position, and if the patient is scanned again in the prone position, the heart moves anteriorly closer to the chest. Other abnormalities of the pericardium that we may encounter on CMR are these pericardial cysts. They have a very typical appearance. They're typically round with no irregular shape. And typically on T2 star images, they should give this bright appearance suggestive of the fluid they contain. They rarely cause symptoms, but here you can see a very large pericardial cyst on T1 images and T2 images, which causes a constrictive physiology of the heart. And in this case, the cyst had to be removed because the patient had symptoms. Pericardial masses are again rare, but if we see, masses in the heart that are malignant, they typically have an irregular shape. They may uptake late gadolinium and be perfused at first pass perfusion. Typically, malignant masses do also have pericardial effusion. So some appearance of the mass on CMR can give us some indication of whether the mass is malignant or not, like increased T2 stir signal, perfusion, and late gut uptake, and of course, whether they are irregular in shape and whether they infiltrate myocardium and surrounding tissues. And therefore, the multimodality imaging of pericardial diseases, all imaging modalities are of value in pericardial syndromes. Pericardial thickness can be assessed by all modalities, but preferably by cardiac CT, which can also visualize pericardial calcification. CMR can be used to get a variety of information, including anatomical information on pericardial thickness. Constriction can be imaged and visualized by all modalities. Echo gives some characteristic features like the annulus reversus. CMR and cardiac CT, when we take both systolic and diastolic phases during deep inspiration, can give this characteristic septal flattening appearance, which is suggestive again of pericardial constriction. Effusion can be assessed by all modalities, particularly by CMR and cardiac CT. T1 mapping on CMR can also give some indications about the type of effusion, whether it is transsudate or exudate. While inflammation, echo gives limited information about pericardial inflammation. This can be assessed mainly by CMR and on particular occasions by PET. As I said, tissue fluid characterization, all modalities, but particularly CMR can give information about tissues with the combination of different sequences, and finally pericardial calcification. Echo can give some indications, but of course, the use of cardiac CT is the gold standard to see calcium and a thickened and calcified pericardium. So in conclusion, I would say that echo is the first imaging approach in the diagnostic workup of pericardial syndromes. Pericardial LG late gut by CMR should be considered among the main diagnostic criteria for acute pericarditis, and we await in this part of the globe the new ESC guidelines, the new European guidelines, where pericardial LG should be included among the main diagnostic criteria. CMR has also excellent diagnostic accuracy for constrictive physiology, and the evidence of inflammation either by increased C-reactive protein levels, but most importantly by pericardial LG, can guide treatment decisions in recurrent and constrictive pericarditis. CT, cardiac CT, can mainly used to detect pericardial calcification and constriction, while PET may be useful in particular cases like cases of pericardial tuberculosis or the assessment of solid tumors and masses of the pericardium. Thank you.
Well, Alexios, this was what I tend to say is a tour de force through the entire use of imaging in pericardial diseases, and I think pericardial diseases is one of those that I think imaging is essential. I think that as you demonstrated from A to C, how important imaging is in the diagnosis, particularly given, as you mentioned, that the diagnostic criteria sometimes can be a little difficult, to establish, based on kind of like a clinical assessment of pericarditis. I think MRI has changed our capability of identifying this disease, and it's even more complicated when you have these patients. Many of us who have seen these patients in clinic. Sometimes it's very easy to make the first diagnosis, but and it's still challenging. But it's even more difficult when you have these patients who have recurrent episodes, because some of them can have this kind of chronic pain that it may or may not be related to pericardial inflammation, and you are there stuck trying to understand if this is indeed a recurrence or some sort of like a unrelated process. So I think MRI has is central, but not only in the diagnosis, as you well pointed out, but also in the in the guidance of the treatments that we do, and that's kind of evolving, and I would like to see more of, and it seems like you're already doing it, but in the community, to try to use imaging to not only do that, but just to kind of guide treatment and see how long we're going to treat and so forth. And I have a few questions for you, but I just want to first, before I jump into kind of all the questions, I have many questions here, but I just want to open up for the to the audience, for questions. If you have any questions, just please put it into the Q&A, and I'll try to moderate that and have the debate. So I have one question here for Dr. Lorenzati. Dr. Lorenzati is an imaging cardiologist, already trained in Europe, and we are lucky to have him here with us doing more of the research side of things and some of the projects. And he makes a question here that he said that we talk about particularly the T1 mapping to differentiate between the type of fluid and so forth, and we know about the T2 imaging and T2 stir for edema. The question he poses is like, is there any role for T2 mapping? I mean, maybe when you're like in acute, when the program is not that thick, might be difficult. But we want to hear your input in terms of using T2 mapping as a complement for the assessment of inflammation.
Yes, thank you. So I've showed to you, a case of blunt chest trauma that had also increased signal on T2 mapping in the pericardium. My experience is that I can see on most occasions, high signal intensity of the pericardium on T2 star images, but I find it more difficult to detect increased signal intensity of the pericardium on T2 mapping. And I think this is somehow related on the lower image resolution of the T2 mapping images.
Yeah, I would say that
So,
I think.
my experience, in my experience, T2 star imaging is more useful in the assessment of pericardial inflammation than T2 mapping is.
Yeah, I think I completely agree. I mean, if perhaps if you have like a thickened pericardium and you can have, as you said, well pointed out, I think you have the resolution to discern between one point to the other because the pericardium is very thick, then you might be able to see it, and maybe you have in subtle cases a little bit of higher sensitivity. But I think in the vast majority of cases, we see the pericardium so thin, as you well mentioned, it will be a lot of noise. And sometimes it gets very hard to assess. I mean, we always try to look at it, but I mean, I think Titus steer is probably the way to go, as you mentioned. I had a couple of questions that I just want to. I mean, through the years of training and practice, has been a lot of debate about this particular topic. I mean, it's very well established that when you have high intensity, and I think you were very well pointed out, like you make the point of high intensity LGE in someone who has an acute pericarditis. That's a reflection of inflammation, and that's through the process of neovascularization. Pericardium that doesn't have any vasculature now has vasculature and granulation tissue, and that's how you get the LGE there. However, in someone who has recurrent events and perhaps even some degree of chronic pericarditis, I mean, some of those vessels might persist. I mean, it's not going to go completely away as the inflammation subside. So some of the debates that I've seen in the past is like, does that degree of LGE, of course, it's not intense, but sometimes you have this kind of intermediate LGE uptake in the absence of T2 signal. So is that a reflection of, in your opinion, is a reflection of fibrosis? Is a reflection of some degree of lingering inflammation? Is a mixed component to it? So what's your input in terms of this signal? I know that this is a very loaded and challenging question that we might not have much of information, but I want to see what you think.
No, I totally agree with you, and this is what I tried to point out in my presentation, that if a patient gets an episode of acute pericarditis, we can see the high intensity LG in very early. But if we scan the same patient after the resolution of the pericardial inflammation down the line, 1 year, 2 years after the event, we would still see some mild LG on most occasions. And I don't think that, this is inflammation. There are some, permanent, maybe fibrotic changes of the pericardium. So if I don't see, high intensity LG, I'm very hesitant to call it pericardial inflammation.
Yeah, and that's kind of what most of the consensus
especially in the absence, of other supporting symptoms and evidence.
Yeah, no, I think through my transit in terms of the debate, I think that's what most people tend to say. I think if that's in isolation, it's very mild. I mean, it's very hard to call it inflammation, and especially if you don't have, as you say, the clinical picture that goes with it. We get here some question from I think it's in the Echo Lab, some of the fellows in there. It's like, what are your thoughts about I guess the use of tagging sequences for CMR? Is that useful?